Hello everyone and good evening. Welcome to the webinar series 2 organized by Academy of Health Professions Educators, basically meant for health professions educators during the COVID era. But today, let me introduce the panelists of today's session. The panelists of today's session, which is titled Simulation-Based Learning, we have the lead faculty, Dr. Dinesh Badial. We know Dinesh very well. Most of you know Dinesh very well. He is actually the program director of CMC, Famer Regional Institute at Indiana. He is a professor of pharmacology, and he was also in charge of the CISP module, almost the nation head, I would say, in terms of providing leadership for that. So welcome, Dinesh.
Yeah, hello, good evening, everyone.
The second faculty that we have is Dr. Rushana Shrestha, who is faculty of emergency medicine from Nepal, and it's a pleasure having you on board, Rushana. Yeah, the next faculty is again from CMC Ludhiana, a USIM level 1 instructor. She is faculty of gynecology. And welcome, Dr. Kavita Mandrela.
Good evening, friends.
Yeah, you're welcome. Next, we have on board Dr. Christina George, who is an anesthesiologist at CMC Ludhiana again. Welcome, Christina.
Hello, everyone.
Yeah, thank you, Dr. Siraj and Dr. Sanjay. Now we start with the simulation-based teaching and learning. As you know, presently in this era, we have been shifting because of some regulatory requirements as well as the demand which is there. We are shifting a lot to simulation-based teaching also. So if you look at most of the people who have done a lot of work and experiences that we are trying to go to share that so that in today's learning objectives, the learner is able to see about, be aware about that, familiar with simulation concepts and their applicability, simulation development process, running a simulation scenario, the experiences. We are going to share 4 or 5 scenarios with you, which are being developed and already in use. Some advantages and challenges, and we are going to provide a list of resources also. Now, when we talk about simulation, one of the example which comes to mind is airline sector. Now, looking at the risk there, they have a regular training and retraining, which is mandatory for the safety related issues. Compared to that, the health sector. Now, recently, because of COVID, what is happening? Because of the risk factors. Because of the personal protective equipment, there's a lot of things that in the healthcare, there's a lot of risk factors. And how much we look at training and retraining, maybe number of people never get retrained. And especially simulation, we are not using so frequently. But when we compare the risk in the airline and health sector, it is more in the health sector. But training and retraining is a norm in the airline sector. We look at these components and imitating the behavior of some situations or processes where whether it can be economic, military, mechanical, by means of suitably analog situations or operators, that is simulations, especially for the purpose of study or personal training. Now, going forward to that, looking into that definitions and the comparison with other factors, in healthcare, we can learn in a risk-free environment if we have simulations. Learning becomes interactive. You can actually get a feedback, repeated practice of skills. You can do it multiple times in that environment. There's immediate feedback. You know, this is not, something is not working well. So you can take a corrective action. Realism. That is something which is very, very important for simulations, how realistic those are. That can give you actual feel of doing the same thing on actual human body. And then ultimately, we are looking at transferability. So these are the important components of that. In that point of view, if we look at the first clinical simulators, you see is the obstetric phantom, 18th century. And now we are talking about 21st century. And presently, the entire world is into this COVID emergency. You say because of that, a lot of people have already come up simulations in the COVID. Best example of that is how to use PPE, personal protective equipment. You can take anyone in your house who can be your friend, your brother, or anyone from the family, and do it on each other. Remember, here the risk stratification is very important. So it is not advised that you go into actually that real environment right now. So that can be done through the simulated environment. A lot of free resources are available at Ministry of Health Family Welfare site also. And there's peer-to-peer skill simulation models. So that is also for COVID-19 response. So they start from very simple patient you have who just you want to send home as well as a very severe patient. So that is something the relevance which is coming up. The whole thing, what this is all about that. If we look into this, this we call as simulation learning pyramid. So you plan a simulation, including the learning objective, methodology, and evaluation. Then you actually learn actually run the simulation when you run that scenario. After that, most of the learning happens in the debriefing. And then we expect that because of their work on simulation, these learner will transfer that. And in the actual practice, clinical practice, they will be doing better. So there are a lot of ways to look into that. So one common methodology is you have a first briefing session, which has an introduction, learning objectives, and people get acquainted to that. And then you actually run the scenario. So you need proper space for that. You need to have a role division, who is doing what. And then you have a very specific start points and end points. And we have seen in our scenarios, refreshments also play very role, and it has to be very well placed there. Then you can see the time which is taken by these. Each block represents the time. The debriefing takes the maximum time. This is a guided exploration where you revisit the learning objectives. This is a must. And you maximize the learning, and there's a constructive feedbacks. And this whole process is based on the calls model of experiential learning, where somebody has a concrete experience. For example, when you go through simulation, you have some concrete experience. There's a reflective observation which happens in the debriefing. So that reflections, critical reflections are very important. So abstract conceptualization happens, and then there's again active experimentation, concrete experience. So this keeps on building up. And this is a very common model used as deliberate practice model in various sports activity where they set the goals, keep on raising them. Accordingly, practice keeps on developing, repetitive practice, and then they try to achieve that. So this both calls experiential learning theory and the deliberate practice model, they are used for the simulations in the healthcare too. Now let me ask you, what comes to your mind when you see this picture in context of today's topic, today's webinar's topic? You can send your responses on the chat. And
are practice FNSE, tape consistency of object, breast examination, real look. Orange can be used as a skin to teach suturing. We can use it for simulation of structure. Yeah, method to simulate intramuscular route of injection, numerous compartments inside.
IM injection.
Okay.
You need to learn the skill of peeling it to get to the core. Injection technique can be.
Okay. So you can see so many ideas people have given on a very simple model, which you can see suturing, peeling, of the skin of a cancerous patients and all those responses which Dr. Chinmay has said. Let's take out forward from this. If this is a very simplest model of simulation, we also have some other models. Now please look at this complexity of this model. Please observe this picture carefully. Now you can appreciate that. So there's a person who has a normal legs, but there's a simulated portion above that. So when the students come, they interview this person, everything with the simulated part. They don't know there's a normal leg behind that. So that is something simulation which you can use model, hybrid models like that also. And we also talk about a lot of computer simulations. This is the iHuman, another platform which is available. So they also have, presently everyone is coming for the virtual patient, and this is a virtual COVID patient case. Also there are various stages of the case. So this is another thing you can go into that computer-based or screen simulations. So look at the realism, how realistic they look. Is the orange very real to suturing, skin incision, giving injection, or you need something like this, which is near to realism, or you need something like this, or you need something like this, or you need something like this. Realism is expressed in terms of fidelity. And accordingly, the simulations are divided into low fidelity, like orange, task trainers. These parts we call as task trainers. Medium fidelity, maybe CPR, ALS, all those components come into the medium fidelity. They resemble a bit low fidelity. Realism is not so high. High fidelity, when you have full mannequins like this or this, then you are closing very close to the gap which is there in the realism. There are a lot of other classification, but we are right now going for this only. So it means there are a lot of opportunities which exist now to leverage the existing simulations and other technologies too and apply them to the healthcare. You might have seen Avatar movie. Everyone might have seen that movie. 3D animatrix they have used, robotics they have used. Why not use in the healthcare? Healthcare is actually lagging behind most in using the simulations. Now this is the time for what we want to ask you something about your experience with the simulations. You are getting a poll now. So what we want to ask you, have you used a simulation based session for teaching undergraduate, postgraduate students in the last 1 year?
36% yes, 50% no, 12% partly, 1% do not remember.
Okay, so
73% have voted.
Yeah. So it means most of them are not using it quite regularly. So we have approximately 1/3 who have used it at any one time. So we will discuss about that also, and it's not easy. There are a lot of challenges too. Now, if you look at some of the issues which we have covered earlier, now we wanted to share with you what we have till now seen. Computer simulations, we started a lot of work in 2008. And we are also talking about, so 2008 and 9, when we started to implement these things. And in between, we had a lot of collaborations. We had a lot of faculty development programs on simulation-based teaching. And now in 2020, we are also looking at in situ simulation. We are going to talk more about later. Dr. Rashna will talk to you about that. So when going through these things, we developed a lot of modules. We shared with other people too, other institutions too. What we plan to do now is we go through some scenarios developed by medical college faculties. We welcome your suggestions on that. And these modules we are open to share if you wish to implement in your institutions. In the last slide, we will provide you email and then you can implement that. First one we are sharing with our collaboration with the Rector Clinical Center of Thomas Jefferson University, Philadelphia. We looked at all the procedure and we found in the entire world, this is the commonest procedure, intramuscular gluteal region. So we picked up this one and we had a team. If you see, we divided into the first 1 month was dedicated to develop that. Overall, it took us more than a year. Week 1 was the module planning. So we have outline of the module, finalized and components were developed. Week 2, we have feedback on the developed modules from the faculties. So here I'm talking about a group of 10 people who were working only on the module for 1 month. Remember, only on the module. They were not doing other things. And then feedback on the number of experts. Pilot testing was done with the students and it was finalized. After that, it was implemented on second year undergraduate medical students. And we have done almost 150 students in 2 centers in 2 countries, and we are extending to other centers too. After that, what was the major issues here? I discussed a bit about that. So we had a briefing section, setting the tone. So all the students can come see what is everything is there, how are the things there. We give them learning objectives. They are given handouts. Then we have a space for running the actual scenario. Again, we are rolled out divided. Students know when to start, when to stop, refreshment, everything. Debriefing. Debriefing is described as something like a diamond-shaped debriefing. First, you have a descriptive where we know what happened, analytical, and then we see here some of the non-technical, you can say, skills, and application is what you have learned and what forward you are going to take it. So that is the debriefing session which happens there, which is the most important. People say most of the learning happens in this cycle. Then after that, what usually is the process for any simulations? you build up a storyboard. So in the next slide, we are going to show how to build a storyboard. Storyboard is built up looking at all the components, starting from first thing to end. So we took thousands of pictures of each step. Each step was run number of times. For example, in the US, they dispose of syringes. We have a syringe cutter in India. So some steps country to country specific, we changed that. So we run through this storyboard and we developed the various components of that. Based on that, the first part was briefing presentation. So when a batch of students come, first we brief them what are the LOs today, what we are going to do with that, all the steps. So we go through all the steps with the group of students. And in between, we had discussions with experts. Each developed part, we had a faculty discussions. Each document was sent to comments after every week. So every week, the finalization will be done. It will be sent to the experts in that area. We have some international experts who are leading in these areas. Then various photographs, as I told you, thousands and thousands were taken. Then we have done a pilot testing. So each simulation modules had to go through the pilot testing. This was with the undergraduate medical students. Pilot testing was done. And after that, further in the pilot testing, and after that, we evaluated the module by using these evaluation techniques. First one was OSSET. OSSET is Objective Structured Assessment of Technical Skills checklist for the IM injections. I will show you that. And validation was done by the ENGOF methods. We have multiple experts here coming into role. We also use global assessment, and we also use pre and post scenario-based MCQ test. And survey was also used for students and faculty. And after completion of all these tests, we had another debrief with the full group of students and faculty to know their views on the module. The students were also provided in the last debrief about the correct answers to all the questions. This is the OSET. You can see OSET is these days used number of places for various simulations, and these are approximately we had 23 parameters on that. And this is the global assessment of IM injection procedure. And these were the scenario-based MCQs. These were modified based on the country-specific context. And these were the specific explanatory answers provided to the students after the scenario was over. This was the survey for IM injection, task trainer, module and text list. Remember, it took dedicated 1 hour. The full team was working on this only. They were not doing other works. And then after that, in the next 1.5 years, we implemented on the undergraduate medical students at 2 centers. So I thank the entire team of these 2 centers which were involved here. And coming to that, that was the major module I wanted to show you. The second one was OPC. We are not running through this full module, but in this module, I'm just showing you the glimpses how we are doing this. So you can see here in the introduction, student get acquainted with everything around that. Then they run through the scenario. We have some checklists. In the introduction, we have a presentation where the steps are told, flowchart is given to them. Most of them are given everything, every handout is given to each student. We also use some artificial walls on a bigger screen to give you that simulated environment feel. Okay, these are available, you can use them. We are using them a lot. And then we have a debrief session. And when we actually look at the learning issues, revisit and make sure through the constructive feedback and guided exploration, all the students revisit the learning outcomes. When we were going through these scenarios, most of you earlier asked us, and also here we use a hybrid model. We are not using a mannequin, remember here, we are using a hybrid model and some of the other simulated environment. So if we use a simulated patient, the simulated patient can actually simulate the sign symptoms of a standardized patient. And standardized patient actually this is a patient which has a sign and symptom, but he is taught how to represent that in a standardized manner. So there are slight differences here, but some people use interchangeable terms of these things. Now, thanks. These were the 2 scenarios I wanted to share with you and the development process and bit about the concepts and the theory. But we continue into the scenarios. Now I hand over to Dr. Roshana for that. And Dr. Roshana will start with sharing her experience of handling some of the in situ simulations in her center.
Okay, good evening and namaste from Nepal. I'm Roshna, I'm from Nepal, and I would like to express my gratitude to Dinesh sir for giving me this platform. And before I start, I'd like to thank my timer friends and all my faculties from Nepal. So I'll begin my presentation. So this is where I'm from. This is the Tertiary Care Center, Dhurikal Hospital, affiliated to Kathmandu University. And this is the emergency department where I work in. So the objective of next 10 minutes is actually not just to share what we did in our hospital in regards to in situ simulation, but also visualize broadly the challenges of in situ simulation and how to overcome that. Because what we believe is that in situ simulation is something that should occur in every department, in every hospital for patient safety. We all know that medical errors are very common, right? And what I think is the ones that are published, that are reported, are just the tip of the iceberg. Actually, the problem is deeper, and it's immense inside. And yes, we are humans, right? So we learn from making mistakes. But having said that, are we allowed to make mistakes in our patients? Obviously, no, right? So we should remember the dictum: first, do no harm to our patients. So having said that, simulation is the right forum where we can practice, make mistakes safely without the fear of harming our patient. So now going on to the proper topic, so in situ, or some pronounce it like in situ. So it means in place in Latin. So here what happens is traditionally the participants, the trainee, they go to the sim center and they practice there. But here it's vice versa. I mean, the simulators, the mannequins or whatever is brought to the place where the incidents actually happen. So let's say this is our emergency department. So the simulators are brought to our emergency department, and the team who actually works together in that department, they practice simulation with that particular environment, with all the equipment that they have and the medicines they have. So they practice with their own team in their own environment. And here is some of the examples, like they are using their own defibrillator, their own equipment, and they are teams as in real life scenario. I think it's time for second poll.
23% yes, 65% no, 8% partly, and 5% not applicable. 70% of participants.
Thank you so much, Dr. Sanjay. So that is great. So 23% of us already practice, and most of us do that partially. That's great. So let's go forward. So now it's quite easy, right? We have our department, we have little mannequins. So let's go ahead, right? It's very easy, but actually it's not that easy as we said. If we perform the simulation without preparation, it can actually be chaotic. There are many pitfalls of running simulation without preparation. So it will be chaotic, it will be, it will have negative influence if we give bad debriefing to the participants. It will demoralize them. So we should be very careful when we are running simulation. And the main route to success is plan, plan, and plan. So I would like to repeat some of the statements that Dr. Dinesh had already said, that it is actually not the replacement for clinical experience. No matter how high the fidelity is, we cannot replace our patients. And it's not just that like today I want to do simulation, I'm in mood to do simulation, let's do simulation in this topic. This is not as easy that it is. So it is not something that just happens when you like. And please remember that this is not a place to embarrass our learners. We should be giving proper feedback to them. And the other thing is, we cannot have everything in one simulation. So a simulation should run with an objective, and we should remember that many things cannot be covered in one simulation. So, so these are the things, these are the questions we answer ourselves before we run the simulation. So number one is where. So where do we want to run the simulation? In your resuscitation area, in your OT, your labor room, or where is the place that you want to run the simulation? When is also very important because now we are running in the place where real patient also comes. So, for example, in our setting, we chose the time when the load of the patient was least. For example, in the morning time before the handover, when the night staff would go home. So we would choose that time. And then who participates? For example, for my project for FIMER, I chose just interns, but later on we continued with our multidisciplinary staff, meaning nurses, paramedics, doctors, everyone together. And the other important question is what? So what do we want from this simulation? Again, learning objective should be very clear. And then how? So how are we going to run this? What is the scenario that we are going to give? If participants act in one way, how are we going to lead that? When are we going to finish that? So these are all very important questions and all needs to be planned very well in advance. So behind the scene, so these were the steps that we went. So first of all, obviously, the faculties who would run the simulation should be trained. And this creating the simulation scenario is a very hard work, as Dr. Dinesh said. It is very hard work, and I would like to thank my faculties who worked with me. We looked at the real life scenario. And then the data collection tool is very important as we are doing skill in simulation. So skill checklist is very important. And here I would like to thank my former fellows that who helped me in validating those tools. And then finally the pilot simulation session and simulation is introduced. And finally, we should not forget to take the feedback from our participants. Today I'm going to share the module of cardiac arrest simulation. As we know, when we work in stressful situation, our IQ, it drops rapidly. And maybe that is the reason why we said we should take cardiac arrest, because what could be more stressful than a cardiac arrest event in the emergency, right? So that's why we chose the topic. And I will not go in details of the learning objective of that particular module, but that was based on the latest American Heart Association cardiac arrest algorithm, which you can see on the right. So where? So we chose the resuscitation room of our emergency department because that would be a real place when a potential cardiac arrest patient would arrive. So we chose that place. And the participant, as I've said earlier, it was interns and the new medical officers. As we know, they graduate and they are placed in a situation where they've never been before. And physicians, they come to work to us and they have graduated from different medical colleges. So they have different approach. And again, nurses and paramedics, as we know, we as doctors, we never attend their class, and it's vice versa. And then finally, we all have to come to one platform and perform together. So having team approach is very important, and it's very effective in team communication skills. So these can be your participants as well. And then checklist, which is very important. As you can see, this was the checklist, and this was prepared in Google Form. So in the initial place, there was the brief statement for the faculties to brief. And then the faculties had to note the time to compression and time to defibrillation. Checklist, the critical actions and the scale of 5 with Likert scale. As you can see, here are a list of the critical actions, which reflects the high quality chest compression. And the faculties, they can rate the performance of the students as they perform in any device. And the same for shockwave rhythms, the BTDFs, and for the non-shockwave rhythms assisted with the. So this was the checklist used for the module. So when these plannings all was done, and then at the scene, first is briefing, because briefing is very, very important. Some of them had never participated in simulation, so we should brief them what they're supposed to do, and also brief them that like whatever mistake they make, it will remain there. So we have a saying like whatever happens in Vegas stays in Vegas. So it's the same thing. Whatever mistake they make, it remains there in the simulation place and will not go anywhere. So they should not be very anxious. And also consent if you're taking photograph. So everything is done during briefing. And facilitation is also very important. So we being a teacher, we have tendency to stop them and scold them, saying, "Hey, what are you doing? I taught you just yesterday, and you are doing like this." So we should try to hold us back, but be very vigilant on what they're doing and where to get our simulation according to their preference. And finally, debriefing is the must. If you don't have time for debriefing, then don't do simulation, because without debriefing, simulation is useless. The debriefing is very important, and in debriefing, we ask the participants to talk more than we do. We ask them why do, what we ask them on what they did, why they did, and what would be like they do differently in future. So we ask them to participate rather than us saying you did this wrong, you should do this, rather than that they, as being adult learner, they comment on themselves. So debriefing is very, very important. I'd like to share a small video that we compiled. Let's hope that it plays.
We used that 1 minute before they came in to just prepare everything. And that was very good. So,
there's no part. One, two, three, four, five.
milligram, iron 300 milligram. And so, some medicine which are around the area to close with the next patient. What did you do?
First,
what did you do first? Like the patient was unresponsive, right? So what did you do first? That was very nice. You checked for a response. That was very nice. The first thing if the patient was awake.
Okay, and after the simulation sessions, we took some feedback from the interns and the staff, and it was very encouraging for us. As you can see, like they were not just happy with the simulation, but they were happy that they could discuss the mistake that they made, and they knew what they need to learn for future. And they also commented on the stressful clinical situation, and some of them also commented that they were surprised to know how poor I was in it. So as we know the 4 levels of competencies, like they were initially unconsciously incompetent. They didn't know they were incompetent. So first step, when they did the first simulation, they became consciously incompetent. So they knew that they didn't know well. And then they tried to become consciously competent in the future. And then finally, when the patient arrives, our goal is that they become unconsciously competent. And some of the other commented on the confident level, and they also enjoyed this session. Having an enjoyable learning session is also very important for adults to learn. So these were some of the verbatims on the feedback. So finally, let's discuss some of the benefits. The first one, in our resource limited setting, I'd like to highlight the cost effectiveness of the in-cycle simulation. So whenever we think of simulation, we think of the mannequins. Nowadays there is competition of developing the high fidelity mannequin, and whenever we talk about simulation, we think it's about money and all, but actually it's not that. Simulation is not just a mannequin, it's not just a technology, but it's a technique. And for the fidelity, not only the simulator fidelity counts, but there's fidelity of the environment and the psychological fidelity, which is very, very high in case of in situ simulation. And there were some instances where we even didn't have that low fidelity primitive kind of mannequin, but we had our volunteer who would lie in the bed and then play the role of mannequin for us. It can be run anywhere, even if you don't have a mannequin. And as already said, they can practice in their actual working place. And teamwork, I don't have to repeat that again. The communication improves drastically. And the other thing which I haven't talked before is that of latent safety threats. Latent safety threats, it's actually the hidden threats to the patient safety, which was not recognized before the simulation. And it's not just the individual mistake, but it's about the mistake of the system, the equipment, so which is recognized by doing the simulation. For example, when we did some of the simulation, like we had to change the place where the defibrillator was once the suction was not working, so on. So you can identify those latent safety threats when you're doing the simulation in the actual working place. And the other thing is efficiency. So in this busy time, like how many of us has time to go to the simulation center, which may be a little far from where we work and practice. So, and your administrator may also not be wanting to release you from your work to go to have training. So here what happens is the trainees are also on job, and even the faculties are on job. So it's very efficient for the healthcare provider and for the whole organization. So here are some challenges that we thought we need to address. The one thing is technical and logistic, but I've already said that mannequin is not the only thing. So I think we can overcome this. And the other important thing is patient and family perception. Because when we are doing the simulation, some of the patients are there, the family members are watching, and we really have to counsel them and tell them what is happening. Time limit is another factor. There had been some instances when we had to stop our simulation in between because a real sick patient arrived to our resuscitation bay. So time limit is another factor when we are doing in situ simulation, in contrast to that we do in the sim center when we can have plenty of time there. But here time is limited and we have to be ready that the simulation may be stopped at any time. And the other thing is large crowd, whether they should participate or not, and then obviously the performance anxiety and the privacy issue. So in summary, so it requires less resource. It really increases the realism because we have the environment fidelity and the psychomotor fidelity, and we have multidisciplinary team approach, and then the latent safety threats can be identified.
Yeah. So we are now going to share the next, very briefly share one more scenario. Dr. Kavita Mandrel is going to present that.
Okay, so I will be talking about simulation-based learning as applied to obstetrics. And we all know that obstetrics is a high-risk specialty. And what is the need for doing simulation-based learning in obstetrics? Because it requires availability of skilled workers. And it requires not only education, training, but most importantly, it requires clinical experience. And this experience is required to prevent, detect, and manage complications, which may occur in an unpredictable manner, especially when dealing with obstetrical patients. So because of the sensitive and often emergency nature of obstetrics, students become just mere observers rather than acquiring the functional role. And students, they get less opportunity as hands-on training to manage obstetrical cases. So the doctor trainees, in real life, what happens is the doctor's trainees, they learn the clinical skills on the job while they are assisting and performing procedures. And they get progressively more clinically trained as they get involved into more complex tasks. But with the recent changes in the education system and the increasing social trends in litigation, increasing awareness of patient safety and ethical concerns, there is a greater emphasis on something which is known as operating room efficiency, which involves clinical and motor skills. This is in contrast to the traditional way of teaching in which the students get less practical experience, that is hands-on training. So an acquisition of motor skills are required, and according to Fitz and Posner, this occurs in 3 stages. The first stage is the cognition stage, where the learner attempts to understand the given clinical task. The second stage is the integration stage, where the learner comprehends and performs the mechanics of the particular clinical task. The last stage, or automation, is where the learner performs the task with speed, efficiency, and precision. So simulation allows deliberate practice and repetition of the motor skills or the clinical skills so that the trainee can acquire expert performance. The learner can focus on improvement of the clinical skill by deliberate practice and repetition, and this should always be coupled with reflection and immediate feedback in a risk-free environment. So the learners can successfully master the skills before they move on to real patient environment. So for the simulation to be included in our teaching schedule, we need to first identify the task that is to be learned. The training objectives should be clearly defined. Appropriate training tools to be selected, the environment or the simulation environment and the required equipments, instruments needed to simulate that particular task should be selected beforehand. The task should be demonstrated by the facilitator so that a proper understanding is there for the learners, and then allow the learners to practice on the model or the mannequin. And this has to be guided by immediate feedback immediately so as the learner can rectify their mistakes. So we made a module for obstetrics, and the task was active management of third stage of labor. So the setup was created by my team, and as you can see, my residents and my faculty, they were quite happy doing up this setting up of the simulation lab. You can see them all smiling, and to be very honest, they gave me ideas how to do the setting. So in fact, some of the things I was learning from them as well. So here we see the model for the active management of third stage of labor with the required instruments kept in place so as to deliver the placenta. There's a resuscitation trolley by the side, and everything was kept ready. You can even see the blood which was coming out from the model, and it was to simulate the scene of a delivery which has been just done. So now the task was to deliver the placenta. So it is very important. First was the briefing which was done, and approximate time was allotted for each of the briefing, clinical scenarios, debriefing, and the last was the question answers if they had any. So if you see the debriefing part was for 20 minutes. That is the most important part where we reflect and give feedback, and if there are any mistakes of which the steps have been missed out, that can be rectified. So in the briefing, we did the learning objective, and that was well defined to each participant. That was to demonstrate the clinical skills for performing active management of third stage of labor on a mannequin, and also to describe the three components of active management of third stage. So this was the briefing part which was given by the facilitator. The components of active management of third stage was defined and explained to them, and then was the scenario which was run by my postgraduate students. So the clinical scenario was given as Mrs. X, who has delivered vaginally. The delivery was uneventful, baby was absolutely fine, cried immediately, vaginal bleeding was average, and now the task was to deliver the placenta by active management of third stage. So my residents got involved into this after the briefing, and if you can see in the video,
good morning to all. Today's session will be on simulation-based learning on active management of third stage of labor. And I will be the facilitator for this session, and my postgraduate students who will be the participants. You can introduce yourself.
Good morning, I'm Dr. Jacqueline. Good morning, I'm Dr. Stuti. Good morning, everyone. I'm Dr. Nupur. Good morning, I'm Dr. Soni. Hi, Dr. Ravi. Good morning, I'm Dr. Nandini.
So the learning objective for today's active management of third stage of labor would be to demonstrate the clinical skills for performing active management of third stage, and also to describe the three components of active management of third stage of labor. And we have a clinical scenario where Mrs. X has just delivered. She has delivered vaginally. There are no complications. The baby is fine. Blood loss is average and her vitals are stable. And the necessary drugs which are needed for third stage of management are kept. The oxytocin, misoprostol, and instruments such as uterine clamps, scissors, and we also have a resuscitation trolley for the neonate. The emergency drugs are also kept on the emergency trolley with atropine, soda, bicarb, calcium gluconate, ambu bag is there, the laryngoscope is there, the endotracheal tube, NG tube, and antihypertensives with a cardiac monitor by the side. So now we can start with the clinical scenario. The delivery has been done and you have to perform active management of third stage. We're going to demonstrate the active management of third stage of labor, which has three components. The first one is administration of the uterotomic drug, second is control contraction, and third is uterine massage. First, once the baby is delivered, we'll keep on the maternal abdomen and palpate the abdomen to look if there is any other fetus in the uterus. If not, we can administer any oxytocin 10 minutes added, which acts as a uterotomic drug.
Time of birth at 10 a.m.
So once it's given and by doing delayed cord clamping, we clamp the cord and cut it using sterile scissors. Once we do this, we hand over the baby to the neonatologist for further resuscitation. Going on to the second step, which will be we palpate the maternal abdomen to see if the uterus is well retracted, and we look for signs of placental separation. Like there will be a firm supraglobbular bulge, and there will be lengthening of the cord with sudden rush of blood. Once the uterus is well retracted, we do control contraction, in which the cord is held in between the index and the middle finger, and then we give downwards and forwards direction so that the placenta is removed. And the countertraction is given by the other hand, which is kept in the suprapubic and suprapubic area, and we give countertraction in the upwards and backwards direction. So using this traction and countertraction technique, we pull out the placenta. Once the placenta reaches the introitus, it is held in the hands and rotated so that the membranes are removed as well along with the placenta. We keep the placenta separately in the tray for later examination. Then we go on to the third step, which is the uterine massage. We found in a round manner, we give massage over the uterine fundus till it becomes well retracted. Once the uterus is well retracted, we can stop and look if it is retracted or if it becomes flat. So after that, we look for any lacerations, if any. We can repair them as and when required. For the examination of the placenta, we use the placenta in both the hands and look for any missing pockets if there are any. In both the hands, we face the maternal side upwards. Then for the completeness of the membrane, we hold the placenta from the cord and make the placenta and the membranes hang. Using the outstretched hand, we look for the completeness of the membranes. Yes, it looks complete. If any membranes or part seems to be missing, we can explore the uterine cavity and so that's how we have managed this patient who had third stage of labor. Thank you.
So is it all complete?
Yes, ma'am, I think I have covered all the steps and how to situation.
We can just sit and debrief on the clinical scenario which you have just performed. If you can please sit down. So how do you feel after this clinical scenario which you have done? Do you feel that you have done it properly in step-wise manner?
Yes, ma'am. We very famous equation formula. If we list any steps, if we can do it a few more times, we will be well versed with the actual steps which need to be done in the oxygen. So what happened actually? The clinical scene when you are performing it, what was the sequence? For the active management of the third stage of labor, major three components which we need to be quick. The first one was administration of the control drug. Then she gave 10 minutes IM oxytocin. Once the baby was delivered, the cord was clamped, we delivered the placenta using the low body action and gave it and such. What we could have been a little more differently than what was done.
Bit of more natural environment, like ask that if you have given the baby, that is the baby okay, is the baby crying healthy, and ask the patient that is the patient okay, is she having any pain, and check the vitals of the patient. We should have asked about the baby and we should have informed the relatives as well.
Maybe that communication would have been an ongoing thing during the performance of active management. We have to make sure that the patient is having pain relief, no pain. So communicate with the others also. Do you want to add anything? You had done this.
So I think if we all get the chance to and feedback immediately, we might be well versed with it. So whenever there is any problem, we can actually manage.
You can check the vitals of the patient as well. So I think we have done very well, and everybody performed, and I think you now know the steps and you are well versed with the sequential skills which are involved for active management of third stage of labor. And then this can be moved on to performing the same thing on real patients as well. So that is how you would gain more confidence. Thank you so much.
Thank you.
So after the first pilot session on active management of third stage of labor, the residents were allowed to practice. And this is a practice checklist which was formed according to the WHO guidelines as well as validated by senior faculty and my colleagues in the department. And this is how they practiced in a group as well as on individual basis. Immediate feedback was given to them. And then assessment of the clinical skills was also important. We know that assessment facilitates learning. So this assessment of clinical skills was done by direct observation of procedural skills, that is DOPS. So you can do it on individual basis as well. And we had made an evaluation checklist as well. So the rating has to be done accordingly. And if they were unable to perform the step or some step was missed, that was marked as 0. So simulation-based teaching aids to replicate clinical scenarios. It is well structured and it has to be done in a controlled environment, offers hands-on training, and especially it addresses patient safety and ethics. So it is very useful whether resources are depleted, where the patient number is less, and every student does not get hands-on training because of lack of patients, and also because of the medical legal issues which are involved if they learn on real patients. It also helps to build up interpersonal communication, teamwork, and leadership qualities, and also decision making, and also they are able to prioritize their tasks, and also it avoids the stressful environment when real patients are involved. Some disadvantages are then that it mimics incompletely the real life situations, and because of that there could be defective learning. The cost factor because of the expensive models and simulators, time factor because we need a lot of time for making up these modules, the infrastructure is required, and the technical difficulties may also be there. And one should always remember that training through simulation should be viewed as an adjuvant and not a replacement for learning with real patients. These are some of the models and simulation models which we have in obstetrical lab. And the first one shows family planning model where they can practice property insertion, tubal ligation, and the top model which they can practice perineal suturing, episiotomy suturing. We have an intravascular IM injection model as well. Then neonatal resuscitation and a SIMWOM or a birth simulator, which is can be operated, and they can conduct and learn how to deliver vaginal deliveries, assist breech deliveries, and also can also learn how to perform cesarean sections on this SIMWOM. So these are available in a obstetrical skill lab. And in the end, I would like to thank my team members, my residents, and my assistant professor who were all involved in making up this presentation. And also I would like to thank the organizers and Dr. Dinesh for giving me this opportunity to speak.
So this is the third poll. Would you like to use simulations based sessions for teaching undergraduate or postgraduate students in the next 1 year? You can select your choices.
The results of the poll are 88% yes, 1% no, 11% partly, 2% not sure.
Right. So if we see the percentage, when we started with poll 1, combining who are doing and who are partially doing was 48, and which reaches to up to now up to 88 and 90%.
We have been conducting the hands-on basic life support training for our first year MBBS students as part of my FAMER project. It became a part of the foundation course and has been implemented in the new MBBS curriculum from 2019.
Hello, thank you so much for a wonderful discussion on simulation-based teaching learning. Sincere gratitude to Dr. Dinesh Vadyal, Dr. Kavita Mandale, Dr. Christina Dodge, and our faculty from Nepal. A special thanks to you, Roshana Shrestha.
Yeah, thank you, everyone.
Thank you, everyone.
Thank you so much. Thank you.